All right. Welcome to the Precision Protocol series brought to you by Biocanic. In this series, we nerd out into the world of personalized health, functional medicine, clinical research, and cutting edge wellness strategies. For those of you joining us live today, we'll move into a Q&A session throughout the conversation. So feel free to drop in those questions wherever you're watching. I'm Jeremy Malecha, CEO and co-founder of Biocanic, and I'm joined by my brother from another mother, co-host Brendan Vermeire. But today we're super excited to welcome Dr. Sanjay, who is a board certified cardiologist. But we're going to be talking about why the perfect sleep stack might be failing you and your clients. So let's jump right in. So why in the heck do we have a cardiologist on here today talking about sleep?
I guess everybody else was taken. I'm not sure, but when we look at cardiovascular disease, when you think about risk factors, you think about like cholesterol and blood sugar and blood pressure. And while certainly those are important, for sure, we see a lot of hidden things, right? And a couple of those hidden things that as you start to get that layer deeper in speaking to a cardiovascular patient to really, use this functional medicine mindset of root cause, one of the important causes and factors that we need to look at is sleep. And I think overall, just in health in general, be it metabolic or cancer related or cardiovascular, certainly sleep is, I hate to say the, pun intended, but it's one of these sleeper risk factors that hide in plain sight. And we just don't ask enough about it. And I think as the science of sleep has gotten so much more well established than when I was in med school back in the 1900s, we've learned how important sleep truly is to every aspect of our lives. And so cardiac is, of course, being a cardiologist, so hammer all the world looks like nails. But when I look at almost all of the cardiovascular conditions, sleep is an essential factor, and meaning adequate sleep is an essential factor in keeping us healthy, and also an adequate risk factor and a risk factor in what drives a lot of cardiovascular disease.
Yeah, just for those of you that don't know my bio, I worked over 15 years for ResMed, a sleep apnea company. And so we're very much into at the time, doing a lot of, sleep testing, sleep analysis, understanding how sleep impacts comorbidities. But jokingly, we would always talk about this, go to the payer, hey, look, somebody's got undiagnosed sleep apnea, look at all these comorbidities, all these risk factors, hypertension, other things that are happening. And we would go to the payer and they go, they have the Jay-Z conundrum. We've got 99 problems. Sleep apnea is not one of them. Kick us to the curb, right? But we really wanted a deep dive. So, at Biocanic, we're doing this sleep study with Precision Analytical and the Dutch test and comparing home sleep testing using their Night Owl device. So I wanted to kind of kick it off and just start to talk a little bit about, we talk about sleep, right? Oh, we need 8 hours of sleep, but why is that, right? But now we're getting into, you have your $8,000 8 sleep mattress, you've got your blackout curtains, your blue blockers, you're off TV by 10, but we haven't really dug into the physiology of what that connection is and how it actually manifests itself in those risk factors. So I'd kind of like to maybe get a deep, jump into it, like the quote unquote HPA axis. Brendan, if you want to kind of walk us through, the traditional sleep thinking that you kind of got trained on, and then we can kind of walk into where sleep research is today.
Yeah, it's interesting because we have this kind of whole concept of sleep architecture. And so if we think about different types of insomnia, or then as we look at basically the neuroendocrinology of sleep disturbance or sleep apnea as this kind of hypoxic physiological stressor where we're depriving the body and the brain of oxygen and oxygen tension that can kind of set off this whole cascade that involves the hypothalamic pituitary adrenal or HPA axis. So, what was it, like the 80s or 90s? It was kind of all about the adrenal fatigue model, and cortisol got just so much interest and hype as a biomarker that we can track to kind of gauge the insight into how is the hypothalamus communicating with the pituitary, communicating with the adrenal glands that's on top of the kidneys to release your glucocorticoids and your catecholamines. So getting that surge of cortisol, kind of the notorious, stress hormone, but it's kind of like a get stuff done hormone, not necessarily just stress. It regulates our circadian biology in contrast with melatonin at night, along with the catecholamines, norepinephrine and epinephrine. So we get into this concept of allostasis, or sort of the harmony of your autonomic or automatic nervous system, right? You don't have to think about digesting your food. You don't have to think about pumping your heart, the autonomic nervous system regulates all of that. And so there's the two dominant branches of kind of more the parasympathetic fibers, which is more associated with like the rest and digest or feed and breed. It's recovery, it's digest and absorb nutrients, more anabolic processes, as opposed to sympathetic, that's more get stuff done, fight or flight, let's release the cortisol and the catecholamines to mobilize energy so we have available fuel and ATP to get done what we need to get done. So now the trendy dialogue has shifted from, it went from like adrenal fatigue, HPA axis dysfunction, now kind of nervous system regulation or dysregulation. So then we have a more kind of modern systems biology approach of not just looking at the HPA axis, but how does that tie into the broader like neuroendocrine metabolic axes for whole body health. So this is where we can kind of expand the conversation, especially with the new data that you're compiling.
Yeah, no, it's super exciting to kind of jump into that. But, maybe Dr. Sanjay, if, we want to kind of flip that over, there we go. If we want to kind of just jump in. So one of the things that why I brought you in was just to get your opinion on whether you did sleep apnea testing, clinical practice. And now you're kind of, I think you've done a few webinars and stuff, but I'd love to get your opinion coming from traditional healthcare and traditional cardiology. Why was it so important for you? And what was the phrase? And you can use the phrase that you told me once. I think it was at our CHS summit, which was, I think every one of you effers is sleep apnea until you prove otherwise.
Yeah. No, I think that was in a lecture hall. I didn't say effers, but I think I said like 95% of us have sleep apnea in the room or something. Yeah. So in the conventional world of cardiology, when we think of sleep apnea, the first thing for most cardiologists that we go to is atrial fibrillation. And why? I mean, it's basically sleep apnea is essentially somebody choking you at nighttime, right? So every time your body tries to choke you at nighttime, you get this catecholamine surge, you get intrathoracic hemodynamic changes. So now you've got a fixed outlet and you're pushing air against it. So that really causes a lot of weird shifts inside of the heart. And over time, what we see is, in particular with our sleep apnea patients, the upper left chamber of the heart, called the left atrium, starts to dilate. And when we start to see that, one of the first things I think of is sleep apnea, because it's like the heart is trying to push this blood out against a fixed like a wall, basically. And so it has no other option but to change its architecture. But beyond that, AFib, one of the most common causes is sleep apnea. And I think that's probably been the earliest place where we've adopted sleep apnea testing in the conventional world. But now as we start to look at, as Brendan was mentioning, like this fight or flight and all these things, and you're having this inappropriate activation of the nervous system at nighttime, because now you're in this fight or flight mode at nighttime. What ends up happening is you start shifting all of your immune cells. So we talk about this M1 and M2 type of a particular cell called a macrophage. Well, those are the cells that can either be pro-healing or pro-inflammatory, and we shift them into that more pro-inflammatory state. And that's what drives high blood pressure. So there's a clear correlation between sleep apnea and high blood pressure, right? So that's part of that milieu, is kicking off that inflammatory cascade. Atherosclerosis, meaning blockage of the arteries, that plaque buildup in the arteries, right? That is not really sclerosis, it's actually an atheroscleritis. It's driven by inflammation. And so now we're creating this just hot, angry mess of an environment with the sleep apnea, pushing our immune cells from that quiescent, chill, let's keep the peace mode into these militant, angry cells that are just looking to fire off on anything. And you can see then from the cardiac milieu, like I said, atrial fibrillation, not just AFib, but all arrhythmias, changes to the heart, valvular damage. All of these things are driven by inflammation, which is oftentimes driven by sleep apnea. And so as I see it in my practice now that I've converted out of, or transitioned, whatever you want to call it, out of that conventional into the more integrative functional medicine space, when we look for root cause of a lot of cardiovascular conditions, you have to address sleep, right? Mm-hmm. And you mentioned kind of sleep architecture and sleep fragmentation and all of these things. Each of those sleep disorders takes a toll on the cardiovascular system. It's like you're giving yourself, if you have an AHI, apnea hypopnea index of like 30, it's like 30 mini stress tests a night. It's like doing sprints all night long when you're trying to get rest. And that's when your heart is supposed to be able to take a break, right? Normally, what's supposed to happen to our cardiovascular physiology at nighttime, your heart rate is supposed to be able to come down by about 10 to 15 beats a minute, what we call nocturnal dipping pattern in blood pressure. So your blood pressure is supposed to drop about 15 to 20%, and not having that pattern, which we call a non-dipping pattern, is independently associated as one of the strongest risk factors for cardiovascular disease. So now we're not allowing the body to rest when it's supposed to, and we are creating this inflammatory milieu. It's no wonder that so many cardiovascular conditions have sleep apnea as a comorbidity, meaning, comorbidity, that what we call that means, it happens at the same time by some weird coincidence, but it's not a coincidence. I think it's a two-way arrow. It's like a circle, is that sleep apnea begets cardiovascular disease, and metabolic disease begets sleep apnea, right? So it's this vicious cycle that, we need through forums like this to inform not just patients, but the medical community as well.
Yeah. I think maybe it'd be helpful just to kind of talk through, you mentioned the apnea hypopnea index, and we kind of talked about sleep apnea, but really kind of talk about the spectrum of what that number means. Between the diagnostic criteria 15, like everybody knows a severe sleep apnea patient, it looks like a 45-year-old male with a BMI of 40, right? And a neck like a fire plug, right? But what does it mean kind of thinking that lower range where it may or may not be so apparent, but then also speak to maybe, oftentimes it's really associated with females, but, is this also the same for males? And how do you actually think about that as well?
Me?
Yeah.
Yeah. So, first of all, sleep apnea, severe sleep apnea, is exactly that, severe, right? So that's like saying, let's wait till the entire house is on fire before we start putting out putting it out. And that's kind of how medicine is right now, is that we just wait till something is severe, wait till it's stage 4 to intervene. But, I think that's the wrong way to do it. What you want to do is catch the snowball at the top of the mountain, not at the bottom when it's a huge boulder, right? And so as we look at that spectrum, the AHI, which stands for apnea hypopnea index, is how many times per hour you basically have a breathing pause, right? Or a shallow breathing event. That's the hypopnea part of it. So normal is less than 5. So all of us have some of these events, and that's happened to us where you kind of like, you cough and you wake up all of a sudden, right? Like it just happens. Then mild OSA, so a mild AHI would be anywhere from like 5 to 14 events. So there's mild apnea presence, but this is kind of where we need to intervene, right? This is where, the spouse or the bed partner starts to be concerned. And I think this is really where where testing needs to come in, because there are things that we can do, levers that we can pull beyond just BiPAP and CPAP, like oral appliances or exercises or other technologies that you can bring in that can help bring that sleep back into a more normal range. Moderate is 15 to 29. And that's kind of, now that's getting a bit more severe. This is where we start to see like significant metabolic shifts, significant like blood pressure increases. And finally, 30 or more is considered severe sleep apnea. And that's when you really need urgent interventions. That's kind of how we look at it. You kind of mentioned the kind of thick neck and all of that stuff. I remember when I was in med school, we didn't have all these fancy AHI criteria. We would ask, does the patient have a collar shirt size greater than, I think it was 17 or 18, something like that. And that was in and of itself predictive of sleep apnea. And so my crotchety old pulmonary attendings, who were still smoking cigarettes, by the way, on rounds, that's how long ago I went to med school, said, that's all you need to know to diagnose sleep apnea. Well, it turns out that yes, that is one population, but we also have the normal weight individuals that have what's called micronathia. So their jawline, we would call it an underbite, right? Their jawline is pushed back a little bit, and they don't have as open of an airway. And this is a population that I see, these thin, particularly female patients that don't have that big truck driver appearance that we kind of emblazon in our brains of what sleep apnea looks like. So sleep apnea, really, you can't judge a book by its cover. And I think that the important thing here is doing a test like Night Owl, which is a at-home sleep apnea test, because now we can see exactly what's going on in the home environment. When we were doing like in-lab testing, while it's great, standard of care, gold standard, all of that stuff, problem is it takes you know, depending on your geography, it can take anywhere from 3 to 6 months to actually get a spot in a sleep lab. Post-COVID, a lot of the labs I practice here in Orange County, California, so a lot of our sleep labs here actually closed during that time. So now, there's a supply issue, but also being hooked up to these electrodes and wires and things, it creates a really artificial sleep environment in which at least if I were to do it, I probably wouldn't be able to get the depth of sleep that I need. And so it begs the question, how accurate is that test in terms of, is it really truly reflective of what's happening at home? So, so getting back to your original question about male versus female patients, I mean, I do think that while we have these standardized criteria, we have to look at gender specific, but you also have to look at body composition specific and patient specific, right? Because what's the difference really between a apnea score of 29 and 30, right? Like that puts one person in moderate, one person in severe. Like, is it really that different? If patient tells you I wake up every morning with headaches and my jaw hurts because I'm clenching it all night long and I'm just sleepy behind the wheel as I'm driving to work, we need to be able to individualize these things and see it in terms of see these numbers in the context of the patient in front of us.
Yeah. I'd love to kick this over to Brendan. So one of the kind of coming back to the topic around why your sleep sack may be failing you, maybe talk through kind of the historical functional approach to managing sleep. So you've run that hormone test, saliva, urine-based test. You see that diurnal cortisol rhythm out of whack or some other things. Maybe just kind of walk through what that traditionally looks like, because historically I have not seen anybody in functional medicine really doing any type of sleep testing that we're talking about.
Yeah, I mean, I feel like the, diurnal HPA, melatonin, cortisol testing's kind of been the dominant thing, especially the Dutch, easy to mention by name, because we always look for, a lot of people will do the salivary Dutch plus for the cortisol awakening response to see how strong of a awakening response they're really having and see the diurnal rhythm. Or then, something we're often trained to look for is that like relative nighttime elevation where there's just like a little bit of a spike up in that free cortisol kind of more towards the evening. And then especially if you see like a low waking melatonin, for example, and then you're asking them about their quality of sleep and how rested they really feel. I like looking at a lot of different, blood markers as well, different inflammatory or immunological indices that might kind of correspond with this greater, HPA oxidative inflammatory milieu as we're discussing.
Yeah, but I was thinking more along the lines of like the FDN, like supplement stack.
Oh yeah,
right? Because I think at one point there was licorice root or something.
DGL maybe, is that what you're thinking of?
Yeah, like the deglycerized licorice a lot, or without more for gut, but then like the licorice drops to extend the half-life of cortisol, or then like holy basil in the evening, a lower cortisol, or relora, acetitol, all these different kind of adaptogenic compounds to try to bring down the cortisol like in the evening. Of course, all the magnesium and theanine and 5-HTP melatonin, which I take magnesium, 5-HTP melatonin pretty much every night, just as kind of part of that. Then I got my uppers in the morning.
Well, yeah, it's so kind of building on that point, so we are doing this combination of looking at home sleep testing, so doing that apnea hypopnea testing and getting that value and correlating it with the urine blood biomarkers. And what's interesting is if you look at the clinical research historically, there hasn't been really a strong cortisol to AHI or severity of apnea connection. And so that was one of the things that we really wanted to kind of tease out. What we're really learning is the reason being is the cortisol spikes that Dr. Sanjay had kind of mentioned are actually, in thinking about it now, are actually being cleared, right? So that person goes hypoxic, holding their breath, they go sympathetic, cortisol spikes, and then your body has to clear it out right away, right? Because I think, correct me if I'm wrong, that if, we kind of didn't clear it quickly, we would just be up. Right?
Yeah.
Because that would be no different than just waking up in the morning with a general cortisol spike.
Yeah, I wonder what that like mechanism there is, like if it's shifting the liver enzymes to more quickly metabolize it, and like what regulates that, like, with hypoxia inducible factor is a transcription factor that goes with like NF-kappa B, and you have this kind of ROS inflammatory cytokine burst. So I'm curious, like what's controlling the like liver clearance of the cortisol and cortisone.
But I mean, I think even just stepping back from the molecular patterns is that you're forcing the body to engage in something during a time when it's not supposed to be engaging, right? Like it's not supposed to be doing all this heavy metabolizing of enzymes and all of these things. And, you know, as I think of it too, you know, as we look at cardiovascular patients, and I think particularly the link between metabolic disease and cardiovascular disease and sleep apnea, you know, certainly that cortisol spike hits, but I mean, testosterone, right? You make most of your testosterone at nighttime too, right? And so if you're not getting adequate rest, if you're not getting that deep sleep, you know, stage 4 REM type sleep, then testosterone numbers will vary as well. And that then leads into wellness and functioning through the day and all of these other things as well. So I mean, you know, I kind of think of it, you know, an AHI of 30 is 30 stress tests in the middle of the night when you're supposed to be getting rest. Like that cannot be healthy. And I just keep going back to that as the thought experiment in all the different ways that your physiology unwinds, you know, during that time.
Yeah, I think you know, this is something that's come up quite a bit throughout the years with my wife working with clients and stuff, is the general stigma. And you mentioned this, going to a sleep lab in Orange County with all the wires and stuff, is a general stigma associated with the sleep testing. And now when we have, you know, just something as simple as that.
Oh man, it is like super. The first time I saw it, literally, I was like, "Where's the rest of this?"
Yeah,
right. Like I was expecting, you know, I thought this box was coming and it was going to be this big, huge apparatus and all that stuff, and it came in a little envelope. I don't know. I had it on my desk here a little bit ago. And oh yeah, here it is, right there. Comes in this little kit, and I'm like, I think Jeremy, I called you, and I was like, "Where's the rest of this?" And you're like, "Yeah, that's it." I mean, it's such a convenient thing that you can do, and most of us are so accustomed to wearables, like, you know, at nighttime, you know, be it a ring or a watch or a wristband or whatever. So it's just another strap that you know that you wear and gives you this amazing information. You know, that I think really just makes it that much more approachable for anyone.
Yeah, I mean, and I think it's I think this is a great opportunity for where the industry can really advance. Because I mean, as we go back to, you know, the FDN approach, right? Diet, rest, exercise, sleep, and supplementation. So sleep has always been a core component, but it always been, it feels like it's understood, right? Because it, you know, yes, you can do all the things and buy all the tchotchkes, but it doesn't really, you can still have that, you know, with the prevalence 30% undiagnosed with some sort of sleep disorder, breathing, all of that may be just a wasted effort if you don't rule it out the first time.
I mean, these glasses, right, these glasses don't fix anatomical issues.
Yeah.
I mean, like when I think about like all of the things that come across my desk, or all the, you know, I've probably in my medicine cabinet, I've got like sleep peptides that people have, you know, tried me to get, or, you know, got me to try. And, you know, you mentioned magnesium and theanine and all of these things, which are great, you know, for we call supratentorial, kind of the brain level issues of you're activated, you're not clearing your brain, you've got erasing all that stuff, right? Your thoughts are erasing all that stuff. But, you know, again, if there's an anatomic issue, we need to find it, right? And that's driven by sleep apnea testing. And, you know, somebody is saying, you know, they feel that sleep owl is very inaccurate. You know, again, you know, in lab testing is the gold standard, right? And so part of it depends on, you know, are we setting this test up correctly? You know, is the patient a proper candidate? A lot of that stuff. So, you know, I think that any test beyond the gold standard, right, is there's always going to be someone that it doesn't apply to. And that, again, that's where I'm saying you have to look at, from a personal standpoint, the patient in front of you. Does this data make sense? You know, and then, you know, use your clinical judgment beyond that, right?
Yeah, and I saw Catherine's comment there around the sleep owl. I think she means night owl is very inaccurate. I know that we had to like coach our participants that you can't like be super tight. It has to be just you know, just lightly taped on there. If you do have those side by side, definitely go back to the manufacturer if there's accuracy concerns. But yeah, in lab is definitely the gold standard. But part of being able to kind of change the perspective on sleep is accessibility and cost. Right. And when you have a home sleep test at, you know, $300, $350, including an interpretation, that really opens the door. And I don't remember, Dr. Sanjay, if Were you around when they used to have like 3-month waiting periods for sleep labs?
That's like now, not like back in the past. Like right now, if I try to apply or prescribe a sleep test, it's at least 4 to 6 months to get somebody in. And then by that point, just speaking as a clinician, the urgency that you've communicated to patient to, like, imagine I tell you, Mr. Jones or whatever, right? You've got this urgent condition that we need to address because it's putting your heart at risk. We're going to work this up in 6 months, right? I mean, there's a communication gap there in the urgency that I'm communicating and that time lag of getting them actually checked. But I think even more so, people just forget. I mean, we're grown-ups and we're being pushed in this way, that way, and the other. And like if I don't reply to an email within the first 30 seconds of getting it, it's going to be forgotten forever because there's just this pile of thing that happens again and again. And now you're asking somebody 6 months from now to do this. It's just, there's a big gap in the industry. Right. And I think that like tests, like home tests, like Night Owl and things can certainly help complement, that gap. And like you said, bring it into a more tactical zone where people can actually get it done.
Yeah. Question from Kimberly O'Brien from YouTube asked, do the orthodontic devices that pull out the top jaw to correct an underbite also open up the airways enough to cancel out the increase? So that pull the top jaw.
Yeah. So these devices that bring the jaw forward to kind of open the airway, I think is what she's
Isn't that the
asking about.
bottom jaw though? So there's the
bottom jaw. You can't really move the top jaw, but I'm assuming that that's what, just the mandible is the mobile. You can't like move the whole skull forward, right? It's the jaw.
Yeah.
And they are certainly helpful. And again, that's somewhere where in that mild to moderate sleep apnea or that sleep disordered breathing, I think that's when those sorts of devices are appropriate and should be used. I mean, there's a lot of, in my area here locally, there's a handful of sleep dentists. They know so much more about the anatomy of the upper face, and they're able to design these things. So, again, I cancel out kind of the risk. I mean, I think we have to be clear about our language here. That may help drive the jaw forward to open up the airway to decrease the apnea hypopnea index. But again, that would need to be like a pre and post type test. And I mean, as you're talking about the lag time of testing, and imagine if you had to wait another 4 months to get into a sleep lab to see if this thing is working, that's 120 days of crappy sleep, as opposed to if you can get like a home-based device and say, hey, you know what, my sleep apnea test improved by 40 or 50% with this oral appliance. That's good news, right? That's a step in the right direction.
Yeah. I've actually been wearing an MAD, MRD, depending on the 3-letter acronym, for over 10 years. So I actually when I did my Night Owl test with my Dutch test, I actually didn't wear it intentionally. So my AHI was 4. So I do snore quite a bit, and Jen will attest to that. And then I wore it on the next night and went from a 4 to a 2, but the sleep quality was tremendously different. So if you look at my Aura HRVs, my HRV tanked without my MRD in or MAD in, and then it went back to normal as soon as I slept with it that night.
Yeah. And I think, and that's a great metric. Most people probably who are watching this, who would take the time to watch a series like this are wearing a wearable, right? You're tracking your numbers, you're tracking your sleep. You mentioned now, 8 Sleep and others are beds that can actually track this for you, right? So we have to realize that it's not just about the snoring. Snoring in and of itself is sleep disordered breathing, right? That may not lead to an elevated AHI. However, when you look at like heart rate variability, if you look at blood pressure numbers pre and post, if you're looking at average heart rates at nighttime that are supposed to dip, right? These are other indices that we're not accustomed to measuring outside of a formal sleep lab that now we have some visibility into with these wearable devices. And mine is right here. I'm trying out the new Fitbit, but so I have one as well. But all these other subtle numbers that we can now measure at home that we know are correlated to not just proper sleep, but proper recovery. And those are two different things, because if you are in, stage 1 sleep for 8 hours, that's very different than if you have normal sleep architecture going between the deep sleep and light sleep cycles. So, it's like in Karate Kid, trust the quality of sleep you get, not the quantity of sleep you get. Right. So, we have visibility now into these other markers. And Jeremy, that's why it's great that you did that, to kind of see, even though my AHI maybe went down by 2 points from not that bad to slightly less not that bad, right? With a HA of 42. You know, when you look at some of these other indices, heart rate variability, sleep architecture, fragmentation, all these things, that's where you start to see these more subtle changes that we are learning are so much more important when it comes to sleep health.
Yeah. And then Brendan, maybe just kind of getting your thoughts. So we're also seeing some of the data that some of these inflammation markers are increasing with kind of some other with the level of desaturations from measured by pulse ox. So maybe just get your thoughts on those couple different markers and what you think might be happening there.
Yeah, well, I like how Sanjay was thinking through that of like bringing up the macrophage activation and polarization. Because I mean, as I was listening, I was kind of thinking through it's like the chicken or the egg, right? Of like, what are some of the obvious or non-obvious factors that might be driving the sleep apnea to begin with? Like, is it more of a deviated septum and an anatomical issue? Is it obesity and metabolic illness? Is it alcohol is a big driver of sleep apnea. Like I don't really drink much at all anymore, but once upon a time when I did actually experience some sleep apnea. It was like one specific night and I shoot up in bed, like gasping for breath. And I'm like, all right, well, never again. Right. But once we have, I like the way it was described as like being choked throughout the night, right? You're literally cutting off your body and brain from oxygen, which sets off this whole immune activation and the immune cell priming and macrophage and microglial polarization. So you have these kind of, pissed off immune cells driving inflammation and oxidative stress. So, I think like the pyroglutamate or 5-oxoproline as an indicator reflective of like glutathione status and oxidative stress, or different inflammatory markers like the quinolinic acid, which is directly reflective of macrophage polarization into that pro-inflammatory N1 phenotype. So, I mean, those have been like two of my favorite organic acid markers for a long time, is the pyroglutamate and quinolinate, and you have both of those on the Dutch test.
Yeah. And so when the quinolinate is elevated from neuroinflammation, what does that typically present as?
Yeah, so like if we could do like a cerebrospinal fluid quinolinic acid, like that would probably be more from the microglia, and then like the urine quinolinate probably more the peripheral macrophage. But I still like, because of even like cytokines being able to cross the blood-brain barrier, and then you kind of get into the whole, hyperpermeability conversation, like I think you can make a strong argument that even like a urine quinolinic acid could possibly be reflective of not just like inflammation, immune activation in the periphery, but maybe there is that glial activation in the brain as well. And when you have that kind of cytokine oxidative storm, you think about insomnia, you think about anxiety and kind of that glutamatergic activity, or you think about, I mean, the whole depression model and anhedonia and lack of pleasure. I mean, you can very quickly start cascading into a lot of different, mood, mental, cognitive delays or disorders. And then there's this whole neurodegenerative spectrum. But I think when you have that increasing hypoxic insult, it does drive that storm in the brain that can contribute to the fatigue and apathy and all sorts of mood issues and cognitive delay.
Yeah, in cardiology, when you have a heart attack, and you open up the blood vessel, you get this flood of blood that comes in, and you can get something called a reperfusion injury. So we call it the ischemia reperfusion kind of injury pattern. And so, this could potentially be happening, 30 times an hour, at a microscopic level. And then you add that up to 365 days times how many years this is happening. This is like a death by 1,000 paper cuts, right? It's like the start of that spectrum. And so it adds up. And yeah, I like what you said about the neurodegenerative diseases. Is that, if you're not getting adequate sleep, the lymphatics aren't being activated, right? The GLYMPH lymphatics. So you're not clearing the brain of the waste products. But if you're also then putting those brain mitochondria, brain, heart, liver, those are the top 3 mitochondrial locations, right? If you're not providing them oxygen, what's happening is you're forcing those mitochondria into poor health. What happens when you get bad mitochondria in your brain, over time, you get neurodegeneration. What happens in your heart? You start to get heart failure, which we're seeing is more and more of this preserved ejection fraction type. And what do you get in the liver? Well, you get the liver cells that are having a difficult time compensating. And that may correlate with this metabolic associated steatotic liver disease that we're seeing, this epidemic of that. So, again, it's just take, why is oxygen important? Well, you have to take it into the body to feed mitochondria. So if you're doing anything that prevents your mitochondria from functioning correctly, that's going to have long-term consequences, particularly if it's nightly over the course of 30, 40, 50 years, right? So most of us, the guys on this call, we're probably in that 50 plus or minus 5 years age bucket, and it's these things that we've accumulated over time, if we're not diffusing them, that lead to disease, right? Why are most of the heart attacks I treat guys in their 50s? Well, that's because it's taken that amount of time for these arteries to get blocked and the bad habits to get conferred and turned into disease, right? So that's why we see that. But if you take that kind of spectrum over time, outside of the acute events that can happen, these chronic things, yeah, it's no wonder that sleep apnea has associations with so many disorders.
Mm-hmm. Imagine if you were like tracking, troponin and like neurofilament light chain longitudinally with people like with metabolic illness and sleep apnea and cardiovascular issues. Like I would imagine there's correlation there. It's just like, heart, muscle, brain degenerating over time.
Yeah.
So what do you think? So like, obviously, the cortisol has now made it into the mainstream. I think I just saw Claire Health raise $1 gazillion for a wearable that's going to track continuous cortisol and hormones. Huberman talks about cortisol all the time. Why do either of you think that looking at actual sleep testing isn't in that conversation?
I mean, it's not a lab test, right? Like we like to have a villain that we can blame, and cortisol has just had great brand recognition as this modulator of stress, but there's so many other aspects to stress and so many other things. I mean, for that matter, everyone's wearing a wearable device. Why am I still telling people what heart rate variability is? It's like a free check engine light that we have, right? So, part of the problem, I think, is that the fix, right, is something that people might not want to do, right? So the fix is doing breath work or meditation to release that cortisol, going out and exercise, eating healthier, all the lifestyle things that I do with my patients. It's not an easy situation. And getting back to the sleep stack, I mean, there's like phosphatidylcholine and serine and lion's mane and cordyceps and all of these things that we can push into a pill and give you. But if you're not dealing with the underlying concern of, okay, can you get out of that stressful situation, right? Do you feel safe where you sleep, right? Is the temperature well controlled? All of these other things. I mean, I can give you, 8 pounds of melatonin, but if you're like living in an unsafe situation, or, your body just doesn't feel like it's in a safe situation, it's not going to make a lick of difference, right? So, I think that the easy thing is to recognize, right? The harder thing is to fix. It's like the Seinfeld, you know how to take the reservation, you know how to hold the reservation, right? So we know one of the straw men that we can blame stress on is cortisol, right? And if your cortisol is high, then you're not going to sleep. If your cortisol is high, your blood sugar is going to be off. Your cortisol is that, but we need to do the work to figure out, why is your cortisol high, right? As we look at these numbers, we've all seen these cortisol curves, and if it's elevated at this point, that means this, or that, maybe you're anticipating work stress, or you're worried about getting home to domestic stress, or whatever it might be. So, cortisol is a great marker of that. But, in terms of why the therapy hasn't been there, is because it takes a lot of deep work, probably, and it's multifactorial to get there. It's not just a pill that you can take.
I really like how that was framed, because I mean, it's funny. I mean, my background's fitness nutrition. So, back then it was like a lot of my clients, they were kind of like fitness only, of like, they just want to be put through a workout. They don't want to talk about nutrition or lifestyle. Yeah. And then, these days with my work in the functional space, it's almost like the opposite, where they're very like data hungry. They'll drop, 2, 3, 4, 5K on testing and data, with the hopes of like, yeah, find that villain, find that modifiable data point, throw the pills at it. Because, sleep though too, compared to like a workout that actually, you have to learn how to work out in the proper form and the effort and whatever. sleep is something our body kind of just automatically does. We just sort of automatically pass out and become unconscious. Like I passed out earlier this afternoon for some reason. And, so it's like, how much can you really do? Like with diet, there's so many variables and levers. With exercise, there's so many variables and levers. I think sleep, it's this kind of like mystical, ambiguous thing that just happens to us. So, like, sure, I got the blackout curtains and blue light glasses, turn off the Wi-Fi router and all that, but there's like only so much you can do beyond just like dumping the melatonin and pills down your throat. So, but to the point already expressed, I mean, the whole point of like data collection should be to encourage behavior modification, right? It's the behavior modification that kind of becomes the hard part, right?
Well, and that, Brendan, like when you're working out, back in the early days when you're working out with clients, they're probably so focused on the lift phase, right? But the adaptations, when do they happen? Do they happen while you're lifting? They happen while you're resting, right? While you're recovering, to allow your body to heal from the trauma of the lifts, right? And kind of similarly, I think that most of us are so sympathetically driven, we don't realize it, right? And we almost become like, we almost have this, I call it a cortisol addiction, where if there's no stress in my life, I don't know if you guys have ever had the situations happen infrequently for me where like, boy, everything is going great today. I've got a green, I got green lights all the way, and I went to the bank and I was the first one in line, and all these things happened. Shows you how old I am, is that I used to go to the bank, right? But on days where everything is happening, what happens? You're sitting there and you're like waiting for the shoe to drop, right? You're waiting for something bad to happen because we're so used to having stress. Or when I go on vacation, the first 2 days are me just coming off, I have to kind of deflate from all that stress that I was carrying. I have like one good day in the middle, and then the last 2 or 3 days of vacation is me anticipating all the crap I'm going to have to get back to when I go back home. And when, like, that's why I think reality TV is such a thing, because when we don't have cortisol in our lives, when we don't have drama in our lives, we're so addicted to it that we watch other people's drama and take it on, right? So the whole way society has been set up is kind of backwards, right? Like we're talking about dogs and stuff before. Well, like when you go to the zoo, right, and you see the lions, right, what are they doing 9 times out of 10? I mean, 99 times out of 100, right? They're just sitting there, and it's like you're bored. You're like, oh, these lions are doing nothing. They're broken, right? I want to see them chase, and I want to do that. But in nature, animals and beings are really supposed to be parasympathetic like 99% of the time, and sympathetic for 1%. I feel like we have the opposite of that. So when we look at the reasons why people don't want to sleep more, or focus on that, like the behavioral aspects, is because I think society is just not geared to tell you about the person that sat all day and was serene and at peace and has great family relationships and cooked a healthy meal. No, we're like idolizing the multitasker, the guy that has the rocket ship company and the electric car company and the solar company, right? And boy, how does this guy get this all done? I need to be like that person. And it's just, we're just kind of set up in a way that our heroes are almost the wrong way, right? We should be more excited about the dude that's like playing ukulele on a beach, rather than the person that's shooting rockets into the air.
Yeah. Here's a question for you. Ellen 2863 commented, my husband completed a 2-night sleep image study which suggested upper airway resistance. He's a 50-year-old lean athletic male, excellent metabolic markers, but a CAC score of 150.
Okay. And so we are looking, is this the question we're looking for?
Potential contributors to his CCVD. His report looked very clean from an oxygen standpoint, but showed up significant sleep instability, fragmentation, low REM, and upper airway resistance. Could you briefly explain what exactly upper airway resistance and how does it differ from obstructive sleep apnea? What's the best way to confirm the diagnosis?
Yeah, so there's resistant disease or resistance, which may not be causing a full obstruction, but there may be like an anatomic narrowing. It could refer to and there we have to be the data or the language gets kind of iffy, gets relatively subtle here. So we have to make sure we're not talking about airway resistance in the sense of like resistant airway disease like asthma or emphysema, that that seasonal allergies, that's more of a lung issue. When we're talking about sleep apnea, we're talking more about the hypopharynx kind of up top. So if there is lung like resistant RLD, resistant lung disease, that would be more like the asthma, emphysema type thing where, you may need what's called a bronchodilator to open up the actual tubes of the lungs, if that makes sense. Whereas obstructive sleep apnea is more where the soft tissue of the neck places a pressure and obstructs the airway over time. And while we're at it, let's say I'm going to put a call out to central sleep apnea, which is where the brain just stops sending signals to your body to breathe. That's a whole separate entity, like probably more scary, I think, equally underdiagnosed than obstructive sleep apnea, and something that a formal sleep test is really, the gold standard again for that. In terms of coronary calcium score of 150 in a 50-year-old gentleman, we would have to kind of look at advanced lipids and if there's like oxidized LDL and small LDL particles and that sort of thing. Also, though, in endurance athletes, I've seen a lot of, you see more coronary calcification, even with good numbers. So for instance, like my triathletes, my ultra marathoners, my marathoners, you end up seeing a little bit more wear and tear on those hearts. You also, was mentioning left atrial dilatation before, that top left chamber. So you can also see a little bit more of left atrial dilatation and fibrosis within the cardiac tissue itself. Again, in the cardiology terms, they call it EET, excessive endurance training, which they define as anyone that runs more than 25 miles per week. When I was doing my triathlon and marathon era, that would be like a light week. That would be like a recovery week, right? 25 miles in the week. So it doesn't take much. And so there's like a too hot, too cold, just right amount of exercise. And I think just while I'm on it, and I'd love, Brendan, to get your thoughts, but I think that ideal type of exercise varies with the decade of age you are, because like the stuff I was doing in my 20s is different than the stuff that I'm doing now in my 40s and 50s. And so we have to kind of look at that. So, airway resistance, just getting back to your diagnosis, your question here, Alina, is probably a lung issue. And that might be driven actually in adults. The most common cause of that is acid reflux. So I would have, of course, I'm not your physician, and, there's no doctor-patient relationship here and all those things I'm supposed to say. But that being said, I would look towards, working with your doctor and seeing if there's like a undercover sleep apnea or airway resistance driven by either acid reflux or seasonal allergies.
Oh.
And that's all I've got to say about that. Jeremy is face palming. Oh my gosh, what did I not do right?
I think my internet.
Frozen.
Yeah, I think I'm frozen.
Frozen in the face palm. Oh my gosh.
I know. What a dramatic frame phrase.
Normally I'm in like a weird face like that when I get frozen.
I can't figure what's going. Is my audio still working?
Yeah,
audio
is just fine.
Oh, okay. All right. Well, we'll figure it out. Hey, so Sanjay, just on that, we've had a couple conversations around CAC scores versus Clearly.
Yeah.
You use Clearly. What's your take on that? I was at a conference. They presented that Clearly was inaccurate. Other people swear by it, swear up and down, say it's the best thing for cardiovascular risk assessment. Love to get your take on that.
Yeah. So let me kind of back up. This is like, this is a loaded question, but when we look at traditional stress testing, conventional stress testing, I slap you on a treadmill and either we have a set of EKGs on you or we do cardiovascular imaging with like an imaging agent, be it ultrasound or a radionuclear test. What we were looking for, those tests are really geared towards flow limiting lesions, meaning blockages in your arteries that are 70% or more blocked. Those are the ones that cause symptoms of what we call angina. That's that elephant on my chest, or the pain that shoots to my jaw or my back, or this weird shortness of breath, fatigue, whatever the equivalent is. And when we do stress testing, really we're looking for, is there enough blockage of the arteries that would help me understand this person's symptoms? That, though, being said, is that when we look at heart attacks, the majority of heart attacks are not caused by these 70% blockages, or what are really, in fact, more mature blockages, but rather these 10, 20, 30, 40% blockages that are immature, that have like a thin cap on top, that are really inflamed and angry. And we've had no way to test for that in the last few years. Probably back in the 1980s, 1990s, somewhere in there, this idea of calcium scoring came up. And what that did was that was a low radiation CT scan or CAT scan that delivers radiation to the chest and is looking for calcifications within your arteries. And the reason that was important was because it was kind of the first time where we had insight into individuals and exactly what's going on. So, like, Jeremy, if I scan you, this is what your heart looks like, right? Not some weird number, but this is actually, these are your lungs, this is your heart, these are your vessels, right? So it was revolutionary in the sense that, now we are getting insight into the actual arteries themselves, not just these flow limiting blockages, because you can have calcification in your arteries that does not impede flow. One of the things that I always talk about with my patients is initially plaque spreads outward until you reach the elastic limit of the outside membrane, and then it starts to breach the area of blood flow. So calcium scoring was the mainstay of kind of a mainstay, I should say, of asymptomatic screening for years. Most insurances don't pay for it, but now it's relatively inexpensive. In fact, I've seen it even here in Orange County on a Groupon for like $75. So it's like going out on date night, but you just, get an idea of what your heart's, what's going on with your heart. The problem though is that we had a lot of patients that had zero calcium scores, right? So calcification is an end stage healing process of this part of atherosclerosis. The more calcium you have, that means the more plaque you've got, that means that the greater your cardiovascular risk. And those are vetted out studies that have been proven a million times over. So there's really no debate that if you have a higher calcium score, it's worse than having a lower calcium score. The problem, though, is if you have a lot of these immature plaques, you haven't yet had the time for them to calcify. So now what we're seeing is in the era of smoking, and the good old days, as I call it, of smoking, people tended to present with calcification much earlier in their process because of the irritant chemicals in the tobacco. But now in the newer era, where most of cardiovascular disease is driven by metabolic disease, we're not seeing that calcification as much. So people can carry a much larger soft plaque burden, which is non-calcified plaque, than ever before. So these calcium scores that people are getting, and let's say, a calcium score of 150, which is mildly elevated for somebody in that age group, right? The question behind that question is, okay, well, there's 150 units, or they're called Agatston units of calcification in these arteries, but how much soft plaque is there? And that was a question that we didn't really have visibility into until more recently, through the advent of a kind of a newer version of the calcium score called a coronary CT angiogram. And that study is much more involved, because you have to give IV dye through a vein, but it gives us visibility into the arteries themselves. So we can actually see 10, 20, 30, 40, 50% blockages. We can name those. But we also get visibility into the actual blood vessel health. So now, instead of just seeing calcium alone, I can see soft plaque. And these technologies clearly is one, HeartFlow is the other. They're like, the two competitors in the market, like Coke and Pepsi, or McDonald's, Burger King, kind of a deal. HeartFlow and Clearly, both of these AI enhanced CT scans are able to now quantify how much of that soft plaque there is, but also through a cool, series of mathematical transformations, kind of give us an idea as cardiologists of, is there any obstruction of flow? Because that's only something that you can test on like a traditional stress test. So now with one scan, you can get a lot of information. You can see soft plaque, you can see calcified plaque, you can see the anatomy of the arteries to see if they're normal size or if there's some weird, congenital thing that someone was born with. It gives me much better insight into risk stratification of the individual. So I can say, hey, Jeremy, not to pick on anybody, but this is what your arteries look like. You have a 10% blockage here, you have a 40% blockage here, but the problem with that 40, it's soft. And it's actually really looking kind of angry and plump, like a water balloon about to burst. Let's get you on either lipid modifying therapy or aggressive lifestyle changes, and rescan you potentially in 6 months to a year, or just base it on empirical findings. So I use it a lot in my practice. I think it's one of the tests that does give a lot of information. Like if you're just picking one test to do, I think it's great. You are getting X-ray, you are getting IV contrast. So anybody with like kidney issues where the kidneys might not be working as well, we have to be a little bit cautious. In women, the breast tissue sits in front of the heart. So I don't love just willy-nilly ordering CAT scans of the chest for women, because we don't want to irradiate the breast tissue, particularly if there's a history of a lump or atypia of cells or something like that. But, again, I think it's a great test. It's the test that cardiologists have been looking for. And even in the brief time that it's been available to cardiologists, brief meaning like the last 7 or 8 years, the CAT scan technology is getting so much better, so that we are seeing much lower levels of X-ray dose, of radiation dose, than the CT scan of 7 or 8 years ago. So I think this will be, I'm hoping what it'll be is like the colonoscopy of the heart, right? When you're 45 now, you have to go for getting some sort of a colon cancer screening, either, poop in a cup or do a scope. But I think this is that finally for cardiovascular disease. And when cardiovascular disease being the number one killer of humans on earth, right now we have much better visibility earlier, so we can make the changes, put people through sleep apnea testing, look at their blood pressure. Why, is it dipping? Is it not dipping? Is that driven by sleep apnea? Are you metabolically insufficient? All these other things that maybe that chicken and the egg conundrum of sleep apnea, part of that cycle, and figure out how best to treat this patient as an individual, not just plugging your numbers into a calculator and saying, based on, a population of 48-year-old or 49-year-old people like Sanjay, you have a 12% risk. Well, guess what? When I have a heart attack, I don't have a 12% heart attack. For me, it's binary. It's either 100% heart attack or 0, right? And now I'm excited about things like Clearly and HeartFlow that are allowing us to do a much more personalized approach to cardiovascular assessment, so that we can keep people out of trouble earlier. And that happens in the same way that I was talking about sleep apnea, right? You don't want to wait till you've got severe obstructive sleep apnea to intervene. You want to get in that mild to moderate phase. Similarly, when it comes to cardiovascular disease, we don't want to wait. I'm an interventional cardiologist, so I was a heart attack doctor for 20 years. I don't want to be putting in a stent, right? My whole career is now shifted into, before that happens, what are the 10,000 levers that we can pull before that happens to keep you out of the cath lab, to keep you healthy, so that you never have to get a heart attack. And these tests are just giving us so much more visibility into that. Aren't you sorry you asked that question? I could have gone on for another hour. Let me show you my slide deck.
That was good. I learned a few things there.
Yeah. Well, listen, with the last couple of minutes, why don't you just tell us about, the business, the practice that you're building, what you're focusing on, and where people can get connected with you.
Yeah, absolutely. Thanks. So I am here in Southern California, and I'm just getting my telehealth practice launched. So I do integrative and functional cardiology, where we're really focusing on the mental, emotional, spiritual aspects, breath work and whatnot of cardiovascular disease, diet, lifestyle optimization. If you don't want to see me as a patient, I run diet and lifestyle optimization classes, or courses rather, I should say. And really, just bringing education into the mix. And my goal is to make cancer number one, which sounds crazy, but cardiovascular disease has been the number one killer for so long. Let's give somebody else a chance, right? So I really want to kind of engage that. On Instagram, I am Dr. Sanjay MD, so DOCTOR SANJAY MD. And my practice is called Laguna Institute of Functional Medicine. So our website is www.lagunamedicine.com. And whoever put the banner, it's DOCTOR SANJAY. The other Dr. Sanjay was taken by some dude in India that I couldn't pay enough to get my handle back.
Awesome. Well, it's been great. Appreciate you joining us, weighing in, and really, really great job.
Thanks, and great to meet you, Brendan.
Hey, great to meet you. I love the conversation.
Yeah. Don't worry, you'll see him at a conference somewhere. Probably.
I sure hope so. A4M?
Yeah. Are you going to be at Hicks? I'll come to Hicks. Maybe it's right down the street from me.
Oh, yeah.
Let's do Hicks.
Yeah, awesome. Well, thanks, everybody. Make sure to subscribe wherever you're watching so you never miss an episode. If you have questions, you can still post them. We'll get them over to Sanjay to get a response back to you. But thanks again. Appreciate it. And thanks, everybody.
See you guys.
Have a great day.